Okay, let me share my screen, guys. Here we go. Okay, can everybody see what I have up and can everybody hear me?
Yes.
Yeah.
Okay, thank you so much for that introduction and good morning, everybody. Like Wes said, my name is Ryan Ramphul, and I'm a professor of epidemiology at the University of Texas School of Public Health. And I'm in the Department of Epidemiology, but I really consider myself to be a spatial epidemiologist. Whereas traditional epis, they study patterns of diseases in populations, spatial epis do the same, but with a geographical twist, with an emphasis on the question of where. Now, the funny thing about what I do is, I've been a spatial epidemiologist 10, 11 years, and for the longest time, nobody really cared, right? And then this little thing called COVID-19 hits, and boom, overnight, everybody becomes obsessed with the question of where. Where are cases rising? Where do we need more testing? Where do we need more vaccines? Where do we need more outreach? And, my phone started ringing off the hook, and it kind of hasn't stopped since. But I'm glad we're to the point in the pandemic where we can start asking the question about where as it relates to things outside of infectious disease, because the question of where, it's a very important question when it comes to pretty much every aspect of public health. And so I'm going to get into that right now. This lecture is about using GIS to visualize non-medical drivers of health. But I guess the first step in that is to really, I'm pretty sure everybody on this call understands what non-medical drivers of health are, but sometimes it helps to see it in graphical form to really understand it. So this is a graphic from the Robert Wood Johnson Foundation. Actually, it looks better here. It basically just indicates that, about a person's health trajectory and health outcomes, about 40% is estimated to be related to socioeconomic factors, education levels, job status, family support, income, of course. That's the largest share of what makes up somebody's trajectory. 10% is estimated to be related to physical environment, proximity to major roadways, air pollution, that kind of stuff. The next largest share is health behaviors, not surprisingly, whether you smoke, whether you diet, exercise, alcohol use, that kind of stuff. And only 20% is estimated to be related to actual healthcare. So we're playing at the margins in the healthcare space. If we were to address a lot of the non-medical stuff, the socioeconomic stuff, we would see much better health outcomes. And so with that, let's take a look at some of these health outcomes and how they manifest around the city. So what you're looking at here is a choropleth map of the percent of households at or below 150% of the federal poverty level by census tract, by neighborhood in Houston. I can zoom in so people can see it a little bit better. For those who are unfamiliar with the federal poverty level, which I'm sure nobody on this call is unfamiliar with that, but just in case you need a refresher, it's a metric that's set every year from the federal government, and it's based on household size and adjusted for inflation every year since the 1960s, by the way. And so, as you can see, a family of four making less than $27,750 would be at or below 100% of the federal poverty level. And that same family of four making $41,625 would be at or below 150% of the federal poverty level. Now, the reason I'm showing 150% of the federal poverty level is because oftentimes for certain federal programs, that's the cutoff. You can make a little bit more than the federal poverty level and still qualify for certain federal programs. Now, a family of four making $41,625 in this day and age, that's not a lot of money for a family of four. But as you'll see from this map, let's take a look at this neighborhood right here. There's about 7,200 people living in this neighborhood. 53% of the people in that neighborhood make less than 150% of the federal poverty level. Let's go down to Sunnyside. Okay. There's about 4,800 people living in that particular census tract, that neighborhood. 45% of those people are at or below 150% of the federal poverty level. So as you can see from this map, thousands upon thousands upon thousands of Houstonians make less than that threshold I just showed you, which is not a lot of money. And if you think it doesn't have an effect on their health outcomes, it absolutely does. It has an effect on a lot of things in their life. So let's look at some of those things. What you're looking at here is percent uninsured by neighborhood in Houston. Now, as you can see, it kind of takes the same spatial pattern as percent below 150% of the federal poverty level. The darker brown areas indicate a higher uninsured rate. However, this particular non-medical driver of health is especially acute when you consider the fact that Harris County has the highest uninsured rate in the state of Texas, and the state of Texas has the highest uninsured rate in the entire nation. Now, let's put this in real terms. So let's look at this neighborhood right here. In this neighborhood, there are about 3,100 people. 28% of those people are estimated to be uninsured. Folks, that means that's women not getting mammograms, that's children not getting well child visits, that's preventative care not happening. That is a disaster waiting to happen, in other words. This neighborhood right here has 6,600 people living in it. 34% are estimated to be uninsured. Unfortunately, these are the people that present to the emergency department with late stage cancer because they didn't have the opportunity to get preventative screenings a few years back. And by the time they present to the emergency room with that late stage of cancer, the prognosis is not looking good. It's a sad story when you think about it. And it's a special stain on our particular region. So about 10 years ago, the CDC attempted to really understand the holistic picture of vulnerability in the entire country, frankly. And they created this thing called the Social Vulnerability Index. And basically what they did was they took a bunch of those factors that I've been talking about. Percentage of people by neighborhood that are below 150% of the poverty line, percentage of people with no high school diploma, percentage of people that are single parent households, no health insurance, all those things. And they ranked each census tract from 0 to 1, 1 being your more socially vulnerable, 0 being your less socially vulnerable. And you can see the distribution of how that looks in Houston here. The darker red areas indicate higher social vulnerability. The lighter areas indicate lower social vulnerability. Now I'm going to bring your attention to something now that you probably won't be able to unsee on any other maps of Houston that you look at. But advocates in the region have taken to calling this area right here that I'm pointing to with my mouse the Houston arrow of affluence, because it kind of takes the shape of an arrow pointing to the east side. Now, the Houston arrow is a very high income area. It's a very high education area. And to some degree, it seems to be immune from a lot of the negative health outcomes that some of the lower vulnerability, the higher social vulnerability areas are kind of plagued by. So you'll begin to see this arrow in a lot of choropleth maps that you see because it's kind of just interesting that it takes the shape of an arrow, you know? So let's take a look at how this arrow affects health outcomes. So on the left, you have the choropleth map of social vulnerability that I've been showing you, right? And on the right, you have estimated prevalence of diabetes. So take a look at that. High vulnerability, high diabetes rate. High vulnerability, high diabetes rate. Now, it even manifests in non-diet related conditions. Let's take a look at another one. This is asthma. High vulnerability, high asthma rate. High vulnerability, high asthma rate. It's interesting. I mean, you can go down the list of health outcomes and you'll find that oftentimes they take a specific spatial pattern in this city. But it's not just this city that health outcomes and vulnerability takes a spatial pattern in. Pretty much every major American city has some area that's more vulnerable than the others. Like in Austin, it also goes east to west. The east side tends to be more vulnerable than the west side, although it's rapidly gentrifying. In San Antonio, it goes north to south. The north side of San Antonio tends to be less socially vulnerable. The south side tends to be more socially vulnerable. In Dallas, it also goes the same pattern as San Antonio. North side of Dallas tends to be less socially vulnerable. South side of Dallas historically has been very socially vulnerable. And it's just kind of interesting how these patterns take shape, but you also have to keep in mind that none of this is random. It doesn't just happen randomly. A lot of this is tied to, really dark history and, everything from redlining to segregation to discrimination. And again, it's not just in America either. In other European cities, the pattern of vulnerability is quite stark. And there's been a lot of studies, some pointing to the suggestion that prevailing wind patterns and placement of landfills might have something to do with how cities take shape and where vulnerable populations tend to be placed. So yeah, I just wanted to show you that even non-diet related conditions take the form of high vulnerability. But the scariest one, and the last one I'll show you guys, is this one right here. On the left, you have social vulnerability, and on the right, you have expected life expectancy at birth. And you can see the legend here. This comes from the CDC's US LEAP programs, US Area Life Expectancy Estimates. Now, it's not very easy to create life expectancy estimates. You have to analyze death records and birth records for basically the entire country. But this one is especially scary because it takes the opposite shape. What you'll see is that in low vulnerability areas, there's much higher life expectancy than in high vulnerability areas. But I don't think people appreciate exactly what this means in real terms. So let's take a look. Essentially, let's click on this census tract right here. A child born in this census tract, I think that's like River Oaks or something like that, the River Oaks neighborhood, is expected to live to about 87 years old. Now compare that to a child born in Sunnyside. We're talking maybe 5-6 miles southeast, is expected to live to 73 years old. That's over a 10-year difference in life expectancy just 5 miles away. Look at this census tract, 71 years old. A child born in that neighborhood is expected to live 71 years compared to the 87 years that a child just 5-6 miles northwest is expected to live. So if people tell you that non-medical drivers of health do not affect health outcomes, this is the ultimate health outcome, mortality. And there's a clear pattern that vulnerability is associated with lower life expectancy. And yeah. So with that, I know my remarks were rather quick for the morning, but I'm open to answering any questions. And I also want to mention I'm a very easy dude to get a hold of. We stand up these dashboards quicker than you can change your shoes, my spatial team. So we're happy to create visualizations for any metric that you're interested in looking at. We've done a lot of work in the food insecurity space. We're branching into other areas as well. So with that, I'd be happy to answer any questions.
Feel free to, oh, sorry, I see it. Morgan's raised your hand. Feel free to unmute yourself.
Hello, thank you for the presentation. I joined a little bit late, but one of the things I noticed was just that the arrow, you call it the arrow of affluence. By chance, could you talk a little bit? I heard it called the green arrow. Is there a correlation as well with tree coverage or vegetation in these areas?
100%, 100%. I've done a lot of work on this actually. Tried to write a few grants on this. There's a phenomena that's commonly referred to as the urban heat island effect. And essentially what it is that in affluent communities, there tends to be more tree canopy, more vegetation, which is able to absorb heat in a more efficient manner than more concrete areas or more asphalt areas. And lower income areas tend to have less tree canopy. And so thus, we're talking 7 to 10 degrees higher in some of these vulnerable communities than in River Oaks or West Jew, or even in those suburbs where there's more tree canopy and more places to absorb the heat. And the implications on health are actually very vast. It's a growing body of research. But I mean, when you have one area of town that's 7 to 10 degrees warmer than another, and mind you, this is the area where people tend to use public transit more. People don't have, vehicles that last them a long time. So there's more walking, there's more outdoor construction. There's a lot of health outcomes that could be associated with the fact that it's warmer in lower income areas, or should I say hotter in lower income areas. So excellent question.
Does your lab by chance have any of those graphs to cover that if I wanted to share that?
Oh yeah, we can produce stuff like that, but we're not the only game in town when it comes to that particular health outcome. There's a lot of people studying the effects of extreme heat. Kevin Lanza at the school, he does a lot of work in that space. And yeah, it's a very hot topic, pardon the pun, these days. Yeah. So yeah, you can reach out to me. I can point you in the direction of some good studies. I mean, it's been done nationwide. It's been done in this region. There's been a lot of people that have done a lot more work on that particular issue than myself. So yeah, happy to point you in the direction of that. Very interesting stuff.
We also had a question in the chat about these maps are incredibly telling. Can someone link where we can access this information?
So me and my lab built this. I can share the link with Wes. I'll make it public, share the link with Wes, and then you guys can play around with it. Yeah.
Also, we can put, Ryan has built an incredible dashboard for food insecurity, which we're housing at the center. Ryan, feel free to speak a little bit on that, but we can put the link for that dashboard as well.
Yeah, that's an interesting one. So yeah, we built a regional food insecurity map, and I'm not going to try and fumble around finding the link. If somebody has it, they can put it into the thing because it would take me a while to find it. Because like I said, we build a lot of dashboards. But this one about food insecurity, it's interesting. It shows area level food insecurity estimates. Now you got to keep in mind with a health outcome or look with a topic like food insecurity, that's not something that the census asks. So there's not a lot of good publicly available data on food insecurity. Additionally, food insecurity is something that people experience at different times in their lives. So it's difficult to track. But we utilize data from an organization called Feeding America, which models this data. And to be honest, it's the best data available for this in the absence of anything else. Now, I will say that last month, the CDC put its hat into the ring and tried to model area level food insecurity. And we're in the process of comparing those two metrics from Feeding America versus the CDC. Bottom line is either of these products will tell you which areas of town they expect have more food insecurity than others. And yeah, food insecurity, I mean, people can dedicate their entire careers to studying this phenomena. It's a very interesting phenomena, and it has tremendous effects on health outcomes. But yeah, that's another dashboard we put together. You'll have neighborhood level estimates of food insecurity, county level estimates, and estimates at the congressional district. I remember the topic of this conversation is supposed to be about advocacy, and I think sometimes when you can show health outcomes at the congressional district level, it kind of gets the attention of Congress members. And, honestly, they're the ones that can, with the stroke of a pen, I mean, it's more complicated than that, but they can make some change happen. And food insecurity, there are evidence-based interventions to address food insecurity. A lot of them center around, things like the SNAP program. For some reason, I got an echo. But yeah, the SNAP program, charitable food assistance, lots of potential ways to address food insecurity. They take investment though.
Hey, this is really helpful. This is Lindsay with University of Houston. Do you have all of the maps that you're talking about and then overlay a medical professional shortage? I'm just curious, like, if there is a correlation, I'm sure there is, between how many medical professionals are available in a certain area and the health outcomes as well.
Well, yeah, we've done that in the past. I don't have it on a dashboard off the top of my head right now, but we've looked at medically underserved areas. And yeah, it's actually very interesting. In a region like Houston with the biggest medical center in the entire country, there are medically underserved areas like 5-6 miles from the med center. There's not enough providers per population. However, one has to keep in mind that just the presence of providers does not equal access. It goes back 100%. To the insurance question, but yeah, it's certainly an issue for sure. There are medically underserved areas, like I said, 5 miles from the med center, smack dab in the middle of the fourth biggest city in the country. It's interesting, very interesting stuff.
And just to clarify, so when you send out the link that we can kind of play around with it, will it have that capability as well?
Well, I was just planning to send the link that I just presented. Okay. I mean, you could always hit me up. I can see if I can build you something with medically underserved areas real quick. Oh yeah. Okay. In relation to some other things you want to see. Yeah.
Cool. Okay. Thank you. I appreciate it.
Dr. Williams, you got your.
Yes, Ryan, what a wonderful presentation. I guess what I was wondering about, and I don't want to be cynical here, But a lot of times when we talk about higher mortality rates associated with social determinants of health, it does get our attention, people in the field, but it doesn't seem to get, I think, and it does get legislative folks involved. But I'm wondering, have you been able to tie cost of care associated with it? So folks with gaps in social determinants of health may end up going to public hospitals or private hospitals. I'm sure managed care companies, I know that often United Healthcare, Blue Cross, I think they've all began looking at data associated with the correlation between social determinants of health and higher cost of care. I think that when you begin to put dollar signs on it, it gets legislative folks' attention, since there's a big bulk of dollars in the Department of Health and Human Services going toward care. And so I'm just wondering about that aspect in terms of the cost of care and any other financial kind of constructs that can come from that to kind of show the picture in that area.
You're absolutely right. And, that is something I've wanted to look into for a long time. And actually, Wes, who introduced me this morning and is actually one of the students in my GIS class, he's especially interested in cost and stuff like that. And, it's just a burgeoning area of research that I think you're right. And there's more that needs to be done. That's going to get people's attention. Because intuitively, we all know that prevention is a lot cheaper than treating things when they're stage 3 diagnoses and whatnot. It's just, but you're right. I haven't seen anyone put cost on a map. I think that could really get people's attention. Something we should all work on.
Thank you.
Felicia Latson.
Hi, good morning, everyone. I was curious about the research that talks about the east side of cities generally being intentionally underdeveloped because of the placement of landfills and trade lands and things like that. When I do these kind of presentations, I often reference a TED Talk by Stephen DeBerry that talks about this. So I wanted to see if you could go more into the research that supports that case, and if there's research that does not support that case, can you kind of talk about, is that really turning out to be a valid trend or not?
Okay, so it's not so much that it's always the east side that is the underserved side, but there's always a side that is underserved. Like in San Antonio, it goes north to south. Dallas, north to south. Austin, it goes west to east. Houston, west to east. So it varies, but there is always a side of town that is underdeveloped, and it's oftentimes not by chance. And in terms of research that indicates that, I'd say one of the most famous studies is from a local hero here in Houston, Dr. Bob Bullard, who's like the dean of some school at TSU right now. He used to be, I want to say, in charge of the EPA, and he did a landmark study in the 70s or 80s all over the south of the United States, indicating that most of the landfills in all of these communities in the South are placed in lower income African American areas. And that is a landmark study. Actually, former Congressman, I think current Congressman Al Green was part of that study back in the 70s. He helped as a research assistant in that. It's a phenomenal story. And, Dr. Bob Bullard, he's a local hero. He's here. He's in town. We could have him come and talk about that, his work that he did 30 years ago, because it's still true. It's pretty crazy. So yeah.
Awesome, thank you.
Dr. Banerjee.
Yes, hi everyone. Just wanted to ask Ryan. Ryan, have you looked at changes over time? Because we did some preliminary work in that area, and we found that the pattern has changed over time, which is very interesting. And it would be worth sort of examining what the reasons might be for that change, because it used to be a Y-shaped pattern of vulnerability, and now it looks more like an inverted C pattern of vulnerability, which is like, the arrow is the affluence, arrow of affluence. So there's an inverted C around it of vulnerability. And so I was wondering if you had seen that and if you were interested in examining that.
100%. You guys are bringing up all the hottest topics in research. So one of the hottest topics in research these days as it relates to poverty, Srila and I just got back from a conference on this, is the temporal aspect, the notion of how it goes throughout time. There's these things that the USDA actually recently released, like within the last year. Oh, well, actually, they've been around for a while, but they became popular again in the last year. These things called persistent poverty census tracts. And the idea behind these are census tracts where 20% of the population has been below the federal poverty level for more than 30 years. And there's a lot of, frankly, money from the National Cancer Institute and other institutes being pumped into understanding these phenomena. I have a grant right now from the National Cancer Institute trying to understand the interplay between food insecurity, cancer, and persistent poverty. It's fascinating because there are some neighborhoods that are super high poverty, but they haven't been high poverty for 50 years. Then there's some areas that have been high poverty for 30 years. What is it about these areas that makes them go out of poverty, go in poverty? It's a very interesting thing to study. Is it the presence of Head Start centers? Is it employers coming to town? Is it influx of migration? It's a world of research to be done in that area. And it's actually the next focal point of my particular research, given that one, I have a grant, but I'm going after several more to understand this phenomena. Because you're right. If we can understand what is it that makes a neighborhood change, and does it change for the better, and does it help people, there might be something we could do about it, Yeah.
Thank you.
June?
Hi, I was wondering whether you have looked at or whether there is data out there on advocacy power in the different areas. I just wanted to see if perhaps there was a correlation between areas with low advocacy power or maybe voter turnout and health outcomes.
That's a very good question. That wouldn't actually be that hard to look at. And I don't know of anyone that's looked at that because, yeah, I mean, well, okay, voting happens at the precinct level. You'd have to do some manipulations to convert it to like the census tract level. But yeah, I wonder if like high voter turnout is associated with any of these health outcomes. That's a very interesting question. All of you guys that have these cool research questions, please contact me. I have a whole lab. We can study this stuff. If we formulate the questions well, we can go after funding. We can really put out some good work. That's what my job is. So y'all hit me up. This is a good idea.
Yeah, Ryan, I'm making a list.
Nice.
I think that great topics. The Healthy People, Healthy Democracy folks who came maybe a year and a half, 2 years ago and spoke, they were able to show some of those correlations, June. I don't know if you've checked out their websites.
I will take a look. What was the name again?
Healthy People, Healthy Democracy.
Thank you.
Dr. Clancy?
Good morning. I'm so glad I attended this. I was actually on a call with Harris County Public Health and the CDC yesterday, and they asked, what do you need? And I said, I need mapping. So I work in the world of overdose prevention, and it's very easy to collect data on where overdose fatalities are happening, where people are picked up by EMS, where people are arrested or encounter police, right? Those are tracked by addresses. But I'm wondering, have you ever incorporated qualitative data? Because when I interview police or people who have lived the life of drug addiction, people that are doing outreach, they are able to provide areas where people are buying drugs, but it's not an actual physical address necessarily. So I just wanted to see, for any of your maps, have you ever done qualitative interviews and incorporated that some way?
Yeah, first of all, I mean, that is a fascinating topic, the issue of opioid overdoses. And I want to bring this point up to everybody. What I showed you just a second ago, those are just visualizing rates of data. Spatial epidemiologists in the academic world usually take it a step further, and they do all sorts of statistical testing to understand if, for example, rates of opioid overdoses are higher than you would expect in a certain area, and if there's statistical significance to it. And I've been trying to get a hold of opioid overdose data, like a good, strong, huge sample size data set for a while. And so I need to connect with you on that because I've been trying to do what they call hot spotting of opioid overdoses. Where are there more of these things than you would expect, kind of thing, adding a higher dimension of statistical analysis than what I showed you, just visualization of the rates. So I'm going to connect with you on that. Secondly, as it relates to qualitative data, that's the future. That's the future. That's what everybody is looking into right now, integrating quantitative and qualitative data. And I'll give you an example. In my funded research with the city of San Antonio, and shout out to San Antonio because I think they were quite forward thinking in this. They commissioned school public health to work on a food insecurity needs assessment. And the first part was, the quant stuff I've been showing you, maps of rates and SNAP utilization, this, that, and the other. But a whole year of it, they required that we do qualitative research. We do community conversations. We do focus groups about food insecurity. And then they had this crazy idea, which I'm in the process of building right now. It should be released mid next month. They wanted to crowdsource food insecurity resources at community health fairs and at various health fairs. So they had me build basically a survey that they can administer to the public at health fairs and whatnot. And it's going to auto-populate a map, and that's community-based resources that comes from the community. It's one thing for us to pull together a list of food pantries and food banks. It's a different thing if it comes from the community. They tend to notice things that we as advocates don't notice because we're not on the ground like them. They know that St. Thomas Church on Wednesdays gives out food, even though St. Thomas Church or whatever church doesn't advertise that anywhere. And that's the type of stuff they wanted from this crowdsourced food insecurity resource map. And I thought that was a very innovative idea. And, they're basically just paying me to build it, but I didn't have the idea, they did. And so there's going to be room in the future to integrate a lot of qualitative data. I don't see a reason why we couldn't do something similar for, opioid overdoses or drug addiction hotspots and stuff like that.
Fantastic.
Yeah,
I'll be in touch.
let's do it.
There's been quite a few links shared in the chat. I'm hope I don't miss any, but I saw I don't know if anyone wants to explain them in particular to the audience. But I see here, oh sorry. Danielle, let's see, did one on Food Insecurity Board in City of Houston. Morgan, I believe you sent one on, I don't know if you can explain it more in detail, but sorry if I'm saying this wrong, mimilabs.ai.
Yeah, Mimi Labs, they curate a bunch of public data sets and they make it accessible within a Databricks environment. So if you're familiar using those computing environments, it makes it easy to do data analysis.
Very cool.
Also, Dr. Ramphul, I don't know if because one thing that's been, I know, especially close in the food security work group, but could you maybe show a little bit on the food security dashboard so people have that on their radar?
Okay. Do you guys happen to have the link somewhere handy?
Yes, Naomi, you'd put it in the chat, right? I'll copy it.
Yeah, I'll copy it in again.
Okay.
So you
Thanks,
have it right
thanks.
at the top of the chat.
Okay, cool. All right, let me show this one real quick. Okay, so you can find it here, everybody. And where do I go to actually?
It's right under the resources tab.
There we go. Boom. Okay, so what you're looking at here is another choropleth map of food insecurity rates by county. It works just like the other ones. You can click on a county and understand more about the actual food insecurity rate. Harris County, for example, has an estimated food insecurity rate of 13.8%, estimated child food insecurity rate of 19.8%, which is an important thing to point out. And to some other person in the chat mentioned the idea of trying to understand what advocacy is going on, at least at the county level, we have a list of consortium programs out there. This is from some organization at Rice, organizations that are trying to address food insecurity. Now, this is at the county level, and a lot goes on sub-county. So the next iteration of this would be to try to do this stuff better at the sub-county level. We do have some sub-county information on this particular dashboard right here. So we can turn off food insecurity by counties, I believe. Oh wait, here in the Greater Houston thing, we have it by census tract here for Greater Houston, not for the whole state or anything. But for Greater Houston, we have sub-county estimates of food insecurity. And again, you see the east side having higher food insecurity rates than the west side. Not a surprise. You can kind of see a vague imprint of the arrow right here. But like I said, food insecurity is a more nuanced non-medical driver than most, as it's something that people experience at different times of their life. They lose a job, this, that, and the other. But yeah, some of these neighborhoods, you'll see they have pretty high food insecurity percentages, 22.8%. And the thing about food insecurity is it's not that visible. It could be your neighbor who lost his job and is experiencing food insecurity. And you don't even know. It could be your coworker. And so food insecurity, there's a world to be studied there. But this particular dashboard, you guys could play around with this one. It's got a lot of neat features. But the other thing I was talking about how you can see it at the congressional district level, that's what I was saying. First of all, it's not news to anybody, but congressional districts are absolutely wacko. Like, look at these borders, like it's weird geographically speaking. But whomever the District 18 person is, their food insecurity rate, at least for the people that they govern, 17.8%. Child food insecurity rate, 29.1%. So yeah, there's a lot going on there. Hey, Rosie, I see your hand up. What's up?
Hey, Ryan, it's always great to see you and always great to learn new things from you. I put something in the chat with, I think unfortunately I DM'd Wes, so sorry, everybody. So my question is really this, Ryan. Those of us who aren't in the academic world, and you already said, hey, these maps are available, et cetera, and I know you're going to provide those links, et cetera. But what if we want to have special maps made or things for like, hey, we're looking at some foundation application. How do we go about working with your team or with you and Srila to figure out to incorporate you into an ask? So that, because this takes a lot of expertise and it's one thing to look at a map, it's another thing to understand it. And so we'd want to be able to collaborate that way, but it can't always be free. So could you walk us through a little bit of that process?
Certainly. So yeah, I want to mention to everybody that we are an easy group to get a hold of. Srila set me up pretty well with the Center for Health Equity. I have an entire team of spatial epidemiologists that I'm training. And like I mentioned at the beginning of this call, I mean, we can stand up dashboards quicker than people can change their shoes. So all it would really take for someone like you, all you have to do is call me. But other people that I might not know, shoot us an email. We'll schedule a Zoom call. We'll discuss your needs. We'll talk through it. If it's something that's quick and we can do it for free and quick, we'll do it. If it's something that's more intensive, we can talk about you writing us into grants and this, that, and the other. But yeah, we're available. We're a resource to the community. We're a resource to the region. That's what we're here for,
Yeah, I'll just jump in for a second here, Ryan. I just echoing what he said, we're here as a resource for the community. And Ryan is not exaggerating when he says his phone has not stopped ringing since the pandemic, which is great, right? There is huge interest in data of this kind, which is visual, easy to digest, very strong advocacy attached to it as well. one of the things, if there is interest from this group, and one of the things that we can do is perhaps pull together the group and think about what makes the most sense. Ryan has been very generous with his time, and he's also educated us that, you know, you don't want to use a kitchen sink approach and just throw everything and make a dashboard. You want to be really thoughtful about what data you want to present, what is the story we're trying to tell, and what's the purpose of these dashboards, what are we trying to achieve? And so I love the interest. We want to help support however we can. And if there is a group that we can pull together, maybe that might be a good next step. Wes, maybe if folks can just contact you, you're welcome to contact Ryan as well. But Ryan and Wes, maybe y'all can sort of help, you know, if there's an interest in this work, happy to pull a group together.
I just put my email in the chat, so feel free to reach out. And then, sorry, I don't know what the first, I see M Rose raised their hand.
Hi, Wes, it's Megan Rose. Sorry. I was just wondering if, Ryan, you've done anything with doing correlations between social determinants of health and medical outcomes in any specific instances, and have any maps of that?
Certainly. So that gets to the professor side of what I do. So there's the visualization side of what I do, standing up dashboards, and then there's the publication side of what I do, which is all focused on correlations. It takes a lot of more scientific rigor, and it's less visually appealing. So some of the correlation stuff, some of the heavy statistical stuff is not very easy to visualize. For food insecurity, though, I have stood up a dashboard that shows the SNAP gap, but statistical hotspots of the SNAP gap. What I mean by the SNAP gap is the percentage of people in a neighborhood that are eligible for SNAP but unenrolled. And we did some hotspot analysis and found certain areas of town that have a higher SNAP gap rate than you would expect if it was truly equally distributed throughout the region. So yeah, we do have some more statistically oriented visualizations. Those are less public because it will confuse people. But you're absolutely right to understand that, you know, seeing a visual, what you think might be a correlation, is not necessarily up to scientific rigor. You have to actually test that statistically. And this is kind of a emerging science, to be honest, spatial epidemiology. And so there's a lot of interesting statistical models to test whether an area with high food insecurity and persistent poverty is truly associated with pancreatic cancer or truly associated with breast cancer or something like that. But my lab specializes in that. That's actually our bread and butter. You know, as an academic, I thrive on publications. The dashboards and the visualizations is kind of just something I do on the side. So yeah, we have tons of that kind of work that we're working on right now.
And then I know someone responded directly to Lynn's question, but do you remember what was this which questionnaire was used for the food insecurity data on the county level map that you presented?
Okay, so that's interesting. Very excellent question. So those estimates are produced by Feeding America, and Feeding America is kind of, at least until last month, was the only game in town at providing area level food insecurity estimates. Here's what they did. I'm going to get my professor side now. For each state, they administered the long gold standard USDA household food security screening, like 3 pages. Takes a long time, to a certain amount of population throughout the state. And then in each state, they ran regressions to see what factors are associated with food insecurity. In Texas' case, it happened to be race, ethnicity, employment status, and a few other things. Then they took those estimates and they looked at area level estimates of those things, race, ethnicity, employment rates, blah, 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 and they modeled food insecurity rates at the sub-county and county levels. USDA, CDC, which released estimates last month, which I haven't gotten a chance to play around with, they took a different method. They used the 2-question hunger vital signs screener through the Burfis protocol. It's like a phone survey that they administer randomly in different really big cities. And so, yeah, that's a publication my lab is working on as we speak, trying to compare the CDC's estimates to Feeding America's estimates, because Feeding America has been the gold standard in this for 10 years. And they might still have more accurate food insecurity estimates than the CDC, but we won't know until we test it. Two totally different methods when you think about it. Two totally different methods, you know. One uses a big 3-page screener, one uses a 2-question screener, but to different areas of the state. One does it to the state as a whole, one does it to major cities and state. It's really interesting. I really geek out about this stuff.
I was listening to on because the ACS just released the 2023 data too, and the way they measure insurance too, because that can be changed throughout the year, like food security status. And if it's at one point, that might be underreported, depending if it's collected once or twice. So yeah.
Yeah, all these things are super nuanced. And I mean, even myself, I started, in this business trying to map food deserts back when we thought that was a thing. Now, tons of studies have come out indicating that food deserts, yeah, they're a phenomena, but they're not necessarily associated with food access, food affordability, or food insecurity. So our knowledge on each of these subjects evolves pretty much daily. You got to really keep abreast of the research and understand these things. And even then, things change. I mean, that's the nature of science,
Did anyone else have any other questions? I know there's been lots of resources shared, so make sure to compile this so that we can have that available for everyone.
Wes, will you be emailing this to all of us?
I think that's probably, let's just do that. We can, because that way I can go to the chat, because this is saved on my end, and that way we can have it compiled in a neat format for everyone.
Thank you.
All right, any other questions or comments? And I've got, of course, and I think this goes without saying, everyone, this has been great. So, I mean, great, really interesting, no doubt. All right, well, oh, sorry.
Thank you, guys. Thank you for putting this together.
Absolutely. Okay, well, we'll go ahead and compile this and send it out. And yeah, hope everyone, and also what we'll do too, we record these on our YouTube channel. I can include that in the email as well. But if you're interested, other past networking sessions are there as well. And we'll include that here on our Center for Health Equity YouTube channel. All right, everyone, we'll have a nice Thursday, and thank you again, Dr. Ramphul.
Thank you, Ryan.